Hello guys, welcome to the Systemic Pathology Revision Express. So systemic pathology, I'll be dividing it into two parts. In the first part, the topics covered are mentioned in the particular screen. That is blood vessels, I'll be covering atherosclerosis, and from CVS, I'll be covering myocardial infarction, rheumatic heart disease, infective endocarditis, cardiomyopathies, pericarditis, and vegetations in that particular diseases. Next, moving on to the respiratory system, I'll be telling about emphysema, pneumonia, lung abscess, and bronchiectasis. Next, in head and neck, I'll be concentrating on rhinosporidiasis, pleomorphic adenoma, Warthin's tumor. Okay, these are the things. Next, GIT, it is gastric carcinoma, inflammatory bowel diseases, then polyps of the large intestine, Barrett's esophagus, and Linitis plastica. In the liver, alcoholic liver disease, chronic hepatitis, types of cirrhosis. In the pancreas, acute pancreatitis and cholelithiasis. Okay, these are the things I'll be covering as part of pancreas and gallbladder. And cholelithiasis is a part of gallbladder. Okay, we'll start with the atherosclerosis. What is atherosclerosis? How are you going to define atherosclerosis? Atherosclerosis is an artery disease of layer intima. Okay, the intimal layer is affected here. So, intima is the keyword. Where there is a progressive fatty deposits. There is progressive fatty deposits. Progressive fatty deposits, which they are called as atherosclerotic plaques, caused by multiple factors and genetic and environmental influences. Okay, it is a multifactorial disease which affects the intimal layer, and is having progressive fatty deposits Okay, next, coming on to the risk factors. What are the risk factors? There are two types of risk factors. One is modifiable, you can modify them. The other ones are non-modifiable. In case of modifiable risk factors, it is dyslipidemia, that is the disorders of lipid. You're going to correct it. Okay, if you're having a proper food routine, okay, diet routine, you're going to correct it. Then hypertension, you can manage it. Then smoking, you can cease it. Diabetes, you can limit it. And obesity, you can stop it. And physical inactivity can be modified by becoming active. And non-modifiable risk factors are gender. Okay, like males are more risky than females. Then coming to the age, middle age groups and old age are more commonly developing this atherosclerosis. Then genetic factors, having a history in the family. Coming to the pathogenesis, what happens in the pathogenesis is there is an endothelial dysfunction, basically. That is a main key starter. Okay, that is endothelial dysfunction that has led to the increased vascular permeability, leading to the adhesion of leukocytes and monocytes. Okay, there is increased vascular permeability. If there is increased vascular permeability, the cells will enter into the circulation. Okay, that is leukocyte and monocyte will get adhered. Then accumulation of oxidized low density lipoproteins within the blood vessels, because the patient is having some lipid disorder and there is an accumulation of oxidized LDL. Okay, oxidized LDL. And this LDL, it is not kept quiet. Our heroes, who are those phagocytes or macrophages, what they do, they phagocytose the oxidized LDL by the macrophages to form foam cells. These the fat laden macrophages containing the oxidized LDL, they are called as foam cells. Next, later what happens once these foam cells are formed, the factors are released from the activated macrophages, that is the foam cells. Okay, these activated macrophages and platelets are stimulated. Endothelial injury stimulates the platelets aggregation and the foam cells will lead to the activated macrophages. So once these are activated, what happens? The vascular smooth muscle cell migration. Okay, the vascular smooth muscle cells, they start migrating from their normal place and they lead into the proliferation to one particular site. Okay, they migrate to a one particular site with extracellular matrix deposition. They want some basement membrane for their stability, right? So there is extracellular membrane deposition also with the vascular smooth muscle migration and proliferation. So once this all things agenda that is coming and aggregating in one particular place, what happens later is there is a progressive lipid accumulation. In between them there is a progressive lipid accumulation. Here it is activated macrophages. These are the keywords you must write in your flowcharts. Next, after the lipid accumulation is formed, what happens later? It is calcification. In the last stages, calcification is seen. So morphology, coming to the morphology. Morphology in the gross, what you are going to see is a raised lesion. You can write this one is sufficient. Okay, raised lesion. And they look, how the lesions look? The lesions are pale yellow. Okay, I have mentioned it here, pale yellow, and they are elevated because of aggregation of all these things. There is a proliferation of different cells and they aggregate in one particular space and they elevate with surface ulceration also. Sometimes you can see ulceration also. Next, coming to the microscopy. In the microscopy, I have not drawn the entire slide. You are going to draw it properly in your exams. Okay, so first is the intimal layer inside, then it has the elastic lamina. In the middle you are going to see tunica media, in the last you are going to see tunica externa and adventitia. These are the things. So initially there is early lesion. In the early lesion, what happens is there is a formation of foam cells. What are foam cells? They are fat laden macrophages. Okay, in one particular area this foam cell starts aggregating. So later, as the time passes, what happens is there is a formation of completely established atheromatous plaque, and this is dangerous now. So once this atheromatous plaque is formed, what are the components of this particular atheromatous plaque? One is, as usual, from the outer layer it's adventitia and tunica externa. In the middle it is tunica media. Remember, here the tunica media is normal or there is more. Okay, usually the tunica media is comparatively thicker compared to intima and externa. So but here what happens is there is thinned tunica media. There is thinning of tunica media. Once this all the aggregation forms, it forms like a cap like structure, and that is called as fibrous cap. And you're going to see inflammatory cells. Usually the inflammatory cells are acute and chronic. Both types of cells are seen. If it is taking over a long process, then it is chronic cells, that is monocytes are seen usually, and plasma cells may also be seen. But in the acute inflammation, if it is there, then it is neutrophils. And you are as usually going to see the foam cells. Once there is a chronic inflammation, what is the definition of chronic inflammation? Chronic inflammation is always having repair simultaneously. So that repair, how does it occur? It occurs by fibrosis, and that has led to the fibrous cap formation. Ultimately, at last, it is fibrinoid necrosis. I have told the fibrinoid necrosis happens most commonly in the blood vessels. So what are the consequences of this particular atherosclerosis? One is MI, myocardial infarction. Then it is stroke. Okay, if this particular plaque, that is a blockade, right? It is blocking the normal blood flow. This is the normal blood flow here. Inside you are going to see the blood. But because of this growth, what happens? The impeding of the blood flow is happening. Because of that, it affects various organs such as heart, leading to myocardial ischemia and later infarction. Then in the brain it is stroke. In the artery, because of this there is a turbulence formation, and that has led to the overproductivity of the blood flow. Then that will lead to aortic aneurysm. Most commonly abdominal aorta is affected. Then it is peripheral artery disease, which will lead to the gangrene of the extremities, most commonly seen in the lower extremities. Then it is development of thrombi. This particular Atheromatous plaque can become unstable and lead to the formation of thrombi, that is called as unstable plaque. This fibrous cap is lost in the thrombi, okay, that is called as unstable plaque. This is stable plaque because there is fibrous cap and these structures are concised within the fibrous cap and the smooth muscle cells and the different layers of artery. Whereas in unstable plaque, this fibrous cap is lost and all these things they come outside and they form the thrombi and the platelet aggregate for this particular thing and lead to the formation of thrombi. This is about atherosclerosis. Next, moving on to myocardial infarction. What is myocardial infarction? How are you going to define? It is an area of coagulative necrosis in heart due to acute plaque change, okay, acute plaque is important here, and it is a coagulative necrosis, these are the key points you're going to write in your definition. Then what happens because of this coagulative necrosis, the acute plaque, as a result you're going to end up in myocardial ischemia. Next, coming to the risk factors. So what are the risk factors? Basically obesity, increase in the age, that is old age, sedentary lifestyle without any activity, smoking, males comparatively more than females because of history of smoking, and stress. These are the things which will lead to myocardial infarction. Risk factors and types. What are the types? One is transmural, that is involving all three layers. One more is subendocardial, that involves just subendocardium. So how are you going to call them in other ways? Transmural is also called as ST elevation MI. It is also called as ST elevation MI. Whereas subendocardial, there is no ST elevation. Pathogenesis. So atherosclerosis. Now atherosclerosis has occurred because it is a precipitating event for MI. As I told, what are the consequences of atherosclerosis leading to MI, right? So atherosclerosis with plaque and thrombi, okay, atherosclerosis with plaque and thrombi. Don't say it is plaque, I am spelling it wrongly, it is called plaque. Atherosclerosis with plaque and thrombi. What they do, they are going to obstruct the blood flow and that will lead to ischemia, and ischemia in turn will lead to hypoxia. Once this hypoxia sets in, there is a decreased oxygen demand for that particular tissue and that is causing angina in the heart. That's why you are going to vasodilate the artery. So nitric oxide is given as an anti-anginal drug, remember. Next, what happens is this particular thrombi and plaque, whatever is formed, it is going to be thrombolized because the body will have compensatory mechanism as the time passes and there will be thrombolysis. Once this thrombolysis is occurring, what happens? There is unstable angina. Okay, this plaque is now exposed to the outer environment and there is permanent thrombus formation later. Once this thrombus is permanently formed, what happens? There is necrosis, and coagulative necrosis is called as MI. Okay. Next, myocardial response. How will the heart respond to the different things? So first is onset of ATP depletion. There is onset of ATP depletion, that is within seconds. Okay, onset within seconds. ATP depletes within seconds. Okay, then there is loss of contractility. The heart will lose its ability to contract, that is within 2 minutes. Within 2 minutes the heart will lose the ability to contract. Then there is ATP depletion less than 50% of normal, that is within 10 minutes. Then ATP depletion for 10% of normal for 40 minutes. Okay, then microvascular injury, that will take hours. Next, patterns. What are the patterns? Patterns basically depends on the artery affected. So there are 3 arteries which are commonly involved in the routine practices. One is left anterior descending artery, that is most common, that is leading to anterior wall MI, that is anterior infarct. See, this is the cross section of the heart. This is right ventricle, this is left ventricle, this is anterior, this is posterior, and this is lateral. So basically left anterior descending artery, the name itself says anterior descending, so it is present in the anterior wall of the heart, so it will cause anterior wall MI. Whereas right coronary artery is the second most common artery and it is causing the posterior and inferior infarct. Okay, inferior also and posterior infarct. Okay, because of it is having piva. Okay, there is something called as piva and iva in the Okay, anterior interventricular artery and posterior interventricular artery. Okay, this is most commonly given by the right coronary artery. The left coronary artery gives PIVA and RCA gives IVA, that is anterior interventricular artery. So both of them will may cause the anterior and the posterior, inferior and the posterior infarct. Okay, once this right coronary artery comes from the coronary main circulation trunk, it winds back, so that is why it is causing posterior infarct. Next is left circumflex. Okay, left circumflex. Okay, left circumflex artery, that will cause lateral. Left circumflex will cause lateral artery, lateral wall MI. Next, coming to the gross morphology and microscopic morphology. Within half an hour, it is always reversible. Remember, it is reversible. So in the gross there is no changes. In micro also you can't see anything. Only in the electron microscopy you are going to see the reversible changes of cell injury, that is relaxation of myofibrils and mitochondrial swelling. I have mentioned in the general pathology video that mitochondrial swelling and the organelle swelling, okay, all this and hydropic change will occur in case of reversible cell injury. Remember, because of decreased Na plus K plus AT plus pump activity, there is increased Na influx and water influx and increased K plus efflux, and this has led to the hydropic change. First the nucleus will bulge and nucleus will start undergoing fragmentation of the DNA, and later what happens, the surrounding structures will start getting involved, that is organelle swelling in that endoplasmic reticulum and mitochondrial were the organs which are getting swelled most commonly. Later it is the membrane blobs which are leading to the Mickey Mouse sign on the electron microscopy. Next, from 1 to 4 hours, okay, from the initial 1 to 4 hours you are not going to see any gross changes again. Then you are going to see on the microscopy slight wavy fibers. On the electron microscopy you are going to see amorphous densities. You are going to see amorphous densities inside the mitochondria. From 4 to 12 hours you are going to see the gross changes. Now the gross changes starts appearing from the 4 hours. Remember, from 4 hours gross are going to appear. How you are going to remember? GROS. Okay, GROS, gross, that is 4 letters. It will start from 4 hours. S is repeated, so ignore it. Okay, so what is the change here? There is a dark mottling here. Dark mottling will start appearing. Okay, dark mottling will start appearing. In the microscopy there is coagulative necrosis. Now coagulative necrosis, edema, hemorrhage, these are all seen. From 12 to 24 hours, that is within 1 day, you are going to see dark mottling is complete. Now the heart is completely dark. Now it is very reddish. Okay, then in the microscopy you are going to see the coagulative necrosis is maximum. Now the coagulative necrosis will start increasing and the neutrophils will start appearing here. Okay, within 1 day there is neutrophil infiltration. Next, from after day 1, from day 1 to 3rd day you are going to see mottling, and the mottling is what? Yellow. Now the mottling with yellow tan center. So once here yellow tan is formed, you are going to see the contraction band. Remember, there is contraction band, and the coagulative necrosis will be again present here. There is coagulative necrosis here and neutrophils will become more. Okay, neutrophils will become more. So they are going to ask on which day of myocardial infarction you are going to see the maximum neutrophils. That is from 1 to 3rd day of MI infection. You are going to see the neutrophils maximally. From 3rd day to 7th day you are going to see the hyperemic border. Okay, hyperemic border with yellow tan center again. The border is hyperemic but the center is yellow. So what and all are the microscopic features here? That is a disintegration of dead myofibrils. Okay, there is disintegration of dead myofibrils. All the myofibrils which were there till now, because of ischemia, they have lost and they have become dead. From here they are going to disintegrate. Each cell will start disintegrating. Each myofibril will start disintegrating. Then what are the heroes now? Macrophages will start appearing. That is chronic inflammation. Acute inflammation is done. Now the chronic inflammation will start. So which are the cells of chronic inflammation? That is macrophages. Then from the 7th day to 10th day you are going to see the same maximum yellow tan. Here it was mild, here it becomes maximum. And depressed red tan borders. Here the red was prominent, here it is yellow prominent. Okay, later the macrophage will become maximum macrophages will start. Once the macrophage is started, you're going to see two macrophages, M1 and M2. What is the function of M2? It is always anti-inflammatory and induces the fibrosis. So before fibrosis, what is formed? There should be granulation tissue. Remember, granulation tissue is a healing tissue which is formed just for the fibrosis formation or collagen deposition. Then from 10th day to 14th day, you're going to see red gray depressed border. Okay, here it becomes gray. Remember, reddish gray, slight reddish gray. Then well established granulation tissue. Here the granulation tissue is maximum and the collagen will start depositing now, and slowly the collagen will start depositing. Then from 2 to 8 weeks, what you're going to see, gray white scar, and there is increased collagen. Okay, increased collagen deposition. And after 2 months, it is scar. Okay, scar is complete. Okay, scar is complete on the gross feature. On the microscopic features, again you're going to see dense collagenous scar, excessive collagen fibers are you're going to see. Next, clinical features. You're going to see the chest pain. Precordial is just in and around the chest. Okay, just in and around the chest and radiating to left shoulder and back. It is going to radiate to left shoulder and back. And there is sweating and dyspnea. These are the things which you're going to see. So what are the ECG changes? I have not drawn the diagram here. You're going to draw. So what are the ECG changes? First you're going to draw the P wave. First is P wave, then it is QRS complex. Then from here you're going to show what? ST elevation. Then you're going to show the T wave inversion. This is T wave inversion. Whereas ST segment is elevated. P wave is normal, Q is normal, R is normal, but ST segment is elevated. Next, coming to the biomarkers. So what are the biomarkers you're going to see basically? The biomarkers which are seen are LDH1 more than LDH2. Usually it is reverse or ulta. That is called as LDH flip. Usually LDH2 is more in our body. Then it is increased myoglobin, then troponin I and CKMB. I have not explained how they increase and decrease, what is their peak, when they start appearing. You are going to refer it properly. Next, it is complications. So what are the complications now? Complications of MI. One is aneurysm. Then it is contractile dysfunction because of decreased oxygen demand. Then thrombus formation inside the heart, that is called as mural thrombi. Then rupture. Okay, rupture of the different muscles or rupture of the arteries. Okay, then arrhythmia. What are the arrhythmias occurring? If it is occurring within 1 hour, if the arrhythmia is occurring within 1 hour, then that particular arrhythmia is called as ventricular fibrillation, that is VF. If it is happening after 1 hour, then it is called as supraventricular tachycardia, SVT, not PSVT, it is supraventricular tachycardia. Next, pericarditis. Coming to the treatment, how we are going to treat? We are going to give oxygen supplementation, rest, nitrates. I have not written rest here, write down rest. Then second is nitrates. Third is antiplatelet drugs such as aspirin and clopidogrel. Nitrates will cause vasodilatation and reverse the vasospasm. Okay. Then beta blockers to decrease the myocardial oxygen demand. Generation 2 and generation 3 are used. Okay, generation 2 or 3 is used, not first generation, because they are not cardioselective. Fifth one is prompt reperfusion with proper oxygenation, that will preserve the viable myocardium present. Then it is percutaneous coronary intervention. If there is no availability, immediately you are going to give the antiplatelets. If antiplatelets are given but still it is not working, then you are going to refer the patient to the higher center where they have percutaneous coronary intervention. They are going to insert the catheter and remove the block. Then is CABG, that is what? coronary artery bypass grafting. Okay, that is what done in the last stages, okay, as a last resort. Then it is rheumatic heart disease. What is rheumatic heart disease? It is acute immunological mediated type 2. Okay, it is type 2 hypersensitivity reaction which is recurrent, non-suppurative. It is non-suppurative inflammatory disease, typically follows group A streptococcus pharyngitis within few weeks. So what is the pathogenesis? Once there is a acute rheumatic fever with the streptococcus, once this is formed, then later abnormal humoral and cellular response to the streptococcal antigens. The streptococcal antigens, for them there is an abnormal humoral and cellular response by the body. After this there is antibodies. Okay, first there is antigen, then it is antibodies. First it is rheumatic fever. Rheumatic fever is there, then antigens are there, and for that antigens you need to produce the antibodies which are directed against the cell wall, that is M protein. It is containing M protein. So cross this M protein, it is very similar to the tissue glycoprotein of the cardiac muscles. So these antibodies, they cross react here. They cross react with whom? The tissue glycoprotein of the heart muscle. The tissue glycoprotein of the heart muscle. So once this cross reaction is happening, what happens? There is acute phase damage. Okay, there is a acute phase damage leading to the granulomatous response. Granulomatous response, and that particular body which is formed is called as Ashkoff body. Okay, Ashkoff body. Next, morphology. Morphology, you're going to see pancarditis. You're going to see pancarditis. So what and all comes in pancarditis? One is pericarditis, then it is myocarditis and endocarditis. In pericarditis, you're going to see the inflammation of the pericardium, that is bread and butter pericarditis. Then myocarditis, you're going to see the Ashkoff bodies. So what is Ashkoff bodies? What do they contain? They contain the macrophages and modified macrophages which are multinucleated. They are called as Ashkoff giant cells or Anishkoff cells. Okay, modified macrophages are called Anishkoff cells. Sorry, one is macrophage and one more is modified macrophage. They are called as Anishkoff cells or caterpillar cells. Then you're going to see the fusion of Anishkoff cells, that is called as Ashkoff giant cell. Then fibrinoid necrosis. Fibrinoid necrosis, this is seen in between the myofibrils, and this particular complex is called as Ashkoff body. Then endocarditis. Endocarditis, you're going to see what? Vegetations, basically vegetations. And how are these vegetations in RHD? They are small, okay, warty, and along the line of closure. They are very neat. See here, they are very arranged neat, and they are very small warty lesions. Small warty lesions which are lined in the line of closure of the valves. So chronic RHD, there is a typical pattern of the mitral stenosis or the particular valves and all, that is called as fish mouth appearance or buttonhole appearance in case of chronic RHD. Because of fibrosis, the valves become like a fish mouth. Okay, they become like a fish mouth. They become like a fish mouth or a buttonhole appearance. Then Jones criteria. How are we going to diagnose the RHD? Using the Jones criteria. Or what are the clinical features of RHD? One is major, the other one is minor. In the major, you're going to see the Jones as a mnemonic. JO for joints involvement. There you're going to see the migrated polyarthritis. N is for nodules, and that is in the subcutaneous tissue. E is for erythema marginatum. E is for erythema marginatum. S is for Sydenham's chorea. C is for carditis. C is for carditis. In the minor, what and all you're going to see? Fever, polyarthralgia, prolonged PR interval, increased CRP, increased ESR. These are the lab diagnostic findings. So how we are going to diagnose the case? We are going to diagnose the case using the ASO titers, that is anti-streptolysin O. Anti-streptolysin O titers are increased, and increase in ESR and CRP, they indicate poor prognosis of this particular RHD. And how we are going to treat? Penicillin. So this is RHD. In the Jones criteria, either two major should be present or one major which is associated with two minor, then it is positive disease of RHD. Coming to the infective endocarditis. What is infective endocarditis? It's a microbial infection. It's a microbial infection of heart valves or the mural endocardium, in which the organisms incorporate and proliferate. What they do? Organisms, they incorporate and proliferate. Organisms incorporate. They go inside and proliferate in thrombotic vegetation attached to the injured endocardium. caused by congenital or acquired cause. Okay, so what are the cause? First you're going to mention all the congenital causes. Okay, all the congenital heart disease, that is VSD, ASD, coarctation of aorta, and PDA. What is PDA? Patent ductus arteriosus. Next, old age. Okay, old age patients. Then immunosuppressive patients such as who are on corticosteroids or glucocorticoids or any of the steroid treatment, or HIV patients. Okay, all those, and immunodeficiency disorders, any of them. Then aneurysms and infections such as Staph aureus, Candida, and Hack group, and prosthetic valves who have undergone the surgery and are being replaced by the prosthetic valves. Then it is ESRD, that is end stage renal disease. End stage renal disease requiring chronic hemodialysis. These are the renal causes, remember. Then IV drug abusers. Okay, IV drug abusers, IV drug abusers. Then what are the types? Types are basically there are two types. One is acute, other one is subacute. What is acute type? Occurs in previously normal valve. Okay, it happens in normal valve. Whereas subacute, it happens in damaged valve. It happens in damaged valve. Pathogenesis. What happens? There is endothelial disruption again. Here also it is endothelial disruption, and that has led to the endothelial injury. Once this endothelium is injured, there is a platelet aggregation. There is platelet aggregation. Once this platelets is being aggregated, what it happens? There is a creation of small vegetation. There is creation of small vegetation. So once these small vegetations are formed, they are infected by the microorganisms via bloodstream. Okay, that is called as bacteremia. So this they surpass the immune response. Okay, immune response of the body has been surpassed by those microorganisms, and they enter inside the blood cavity, and they thereby lead to the heart. And in the heart there is already formation of vegetations, and these vegetations are infected by these particular microorganisms. And once this is been infected, how are the vegetations looking? They are looking large, bulky, and infected. Okay, they are large, bulky, and infected. Later this bacteria produces MMPs. What is MMPs? Matrix metalloproteinases, which are required for ECM degradation, which I have learnt in local invasion. So, and destroy the valves there. Okay, for local invasions, and that's why that is leading to the valve destroyment. So once these valves are destroyed, again there is acute over a period of time. If it is short, it is acute infection. If it is taking some time, then it is subacute infection. So what is the morphology? Morphology of the valve vegetations. It is large, bulky, irregular, friable, destructive, infective, irregular, friable, large, bulky. Repeat, they are large, bulky, irregular, friable, destructive, infective lesions along the line of closure. Histologically, what are the things you are going to see? You are going to see platelet, fibrin, thrombin with neutrophils. So what are the clinical features? Basically, you are going to see high grade fever, chills or rigors in case of acute. Whereas in subacute, there are no specific symptoms. There are only fatigue, malaise, weakness. All these things are seen. On examination, you are going to see the cardiac murmur. Murmurs are seen. So what is the criteria which is being used for the infective endocarditis? It is called as Duke's criteria. There are two criteria again, major and minor. In major, it is blood cultures positive and positive echo showing the vegetations. Whereas in minor, you are going to see heart history of heart disease, fever, Janway lesions, oscillous nodes, Roth spots. All these are seen. So organism is positive, but those organisms are not related to the formation of things which are requiring for infective endocarditis. So how is the things? One is 2 major or 1 major plus 3 minor or 5 minor. These are the things. So what are the complications basically? Complications being glomerulonephritis, sepsis, embolization, and arrhythmias if the myocardium is being involved. Okay. So coming to the cardiomyopathies. So what are the cardiomyopathies? They are the diverse set of heart muscle disorders that cause myocardial dysfunction, or you can write as heterogeneous group of disorders of myocardium. Okay, they are the disorders of myocardium associated with mechanical or electrical dysfunction that usually but not invariably, usually seen but not invariably seen. Okay, they are a group of disorders of myocardium. They are disorders of myocardium. What they cause? They cause mechanical or electrical dysfunction of the heart, exhibiting inappropriate ventricular hypertrophy or dilatation. What they exhibit? They exhibit ventricular hypertrophy or dilatation due to variety of causes. Okay, mainly genetic. So what are the types? Primary cardiomyopathy and secondary cardiomyopathy. Primary is most commonly affecting the heart. Secondary, it is associated with some part of syndrome. So what are the other types? How are I going to differentiate? Dilated cardiomyopathy, hyperobstructive cardiomyopathy, and restrictive cardiomyopathy. So in case of dilated cardiomyopathy, there is dilatation of all four chambers. All four chambers, they are going to be dilated. Whereas in HOCM, what is there? There is a beta MHC, that is beta myosin heavy chain is being mutated. That is a sarcolemmal protein. Because of this, there is a loosening of myofibrils. Then in the RCM, it is most commonly amyloidosis, which is the cause. Whereas in DCM, it is idiopathic. There are variety of causes such as alcohol, postpartum myocarditis, and titin mutation. All these are the DCM, that is dilated cardiomyopathy causes. Morphology. In the morphology, you are going to see the pale flabby myocardium in DCM. Whereas what happens here is predominant hypertrophic myofibrils. There is hypertrophic myofibrils and interstitial fibrosis with ninja nucleus. There is something called as ninja nucleus, which is very huge. Then morphology of HOCM, that is hyperobstructive cardiomyopathy. Thickened IV septum. Remember, it is a hallmark here. Thickened, that is a banana split configuration. It's called as banana split configuration or banana shaped intraventricular septum. Then hypertrophied segment is there, right? That particular hypertrophied segment, what does it show? There is increased myocyte diameter, haphazard myocyte bundles, and interstitial fibrosis. That pattern is called as helter-skelter myofiber disarray. So coming to the restrictive cardiomyopathy morphology, you're going to see bilateral dilatation, biatrial dilatation due to increased atrial pressure. What is the microscopic feature here? You're going to see the patchy to diffuse. Okay, patchy to diffuse. There is not diffuse. Patchy to diffuse interstitial fibrosis is seen. Pericarditis. What is pericarditis? It is inflammation of pericardium. Two types, acute and chronic or ill type. Causes infections such as HIV, adenovirus infection, Coxsackie virus infection, TB infection, Candida infection, Chagas disease, and rheumatic fever. Okay, rheumatic fever, SLE, scleroderma, these are all the immunological causes. Other causes are myocardial infarction, tumors, and radiation. Gross. How does the area look? It looks rough rather than shiny, which is normal pericardium, but here it is rough, reddish and inflamed pericardium with exudates. Okay, pus may be there. On examination, fluid which is rich in protein and mononuclear inflammatory cells. What are the vegetation seen in the heart? There are two types. One is infective, other one is non-infective. Infective, there is only one, that is name itself telling it, infective endocarditis. Rest all the things are non-infective, such as rheumatic heart disease, okay, and NBTE and Liebman-Sachs endocarditis. Okay, these are the things. In case of infective endocarditis, you're going to see large, bulky, friable, irregular, destructive masses along the line of closure. Whereas RHD, it is small, verrucous, warty, irregular along the line of closure. All are along the line of closure only, but they are going to differ in sizes. NBTE is again small masses. Okay, compared to RHD, they are big, but they are small. These are very small. RHD, they are very fine and small. Then Liebman-Sachs, going to see masses on both sides of the valves. That is very peculiar for Liebman-Sachs endocarditis. Okay, we are done with CVS. We are entering RS. In respiratory system, first topic is emphysema, which is a component of chronic obstructive pulmonary disease. So there is abnormal permanent dilatation. It is permanent enlargement of air spaces distal to the terminal bronchiole, distal to terminal bronchioles, with destruction of valves and without fibrosis. There is no fibrosis. Remember, there is no fibrosis. Pathogenesis, the most common etiology being cigarette smoking. Okay, what does it do? This particular cigarette smoking will activate the macrophages. Once these macrophages are activated, there is a release of interleukin 8, LTB4 and tumor necrosis factors. What they do? They release proteases. Once these proteases are released, it induces apoptosis. Okay, so basically there is something called as antiprotease in the body, that is alpha antitrypsin, which will inhibit this particular thing. So if this particular alpha antitrypsin is deficient, then it will lead to the increased protease activity, and there is an imbalance. Okay, basically imbalance between protease and antiprotease mechanism will lead to increased elastase activity. So if this elastase activity is increasing, that will lead to digestion of lung tissue, that is called emphysema. So what are the types? Basically centri acinar, pan acinar, distal acinar, irregular. These are the things. So in the central acinar, it is usually in the upper lobe and it is in the central part of acinar. That is why it's called central acinar. Pan acinar, it is involving all layers, whereas distal acinar, the distal part of acinar is involved. Irregular is it can be involved in any area and looks irregular. Okay, this is irregular pan acinar here, and it is centri acinar. This is the terminal bronchiole, in between is respiratory bronchiole, last it is alveoli. So to be specific, if it is happening in the center respiratory bronchiole, it is called central acinar. It is, if it is occurring in terminal bronchiole, respiratory bronchiole, alveoli, everywhere, then it is pan acinar. If it is occurring in the distal acinar, that is in the alveoli, then it is only distal acinar. Irregular is anywhere and it looks irregular. Gross, overinflated lungs. Okay, overinflated lungs, and they are spongy. On cut section, you're going to see distended alveoli and bullae. So on microscope, you're going to see dilated air spaces and destroyed alveolar septum without fibrosis. Okay, destroyed alveolar septum without fibrosis. So next is clinical features: breathlessness, dyspnea, cough, wheezing, and weight loss. They are called as pink puffers because they are well oxygenated and having and maintain normal saturation, whereas blue bottles are others, that is chronic bronchitis. Other forms, what are the other forms of emphysema? One is compensatory. Because of compensatory mechanism, there is emphysema. Then it is obstructive overinflation, then bullous, then interstitial. If you want, you can write them, or else you can, it's okay. If you are not writing also, it's not a problem. Then complications. In the complications, you're going to write coronary artery disease, respiratory failure, cor pulmonale, collapse of the lung due to pneumonia. What is pneumonia? Next, pneumonia is infection of the lung parenchyma distal to the terminal bronchiole, lung parenchyma. And pathogenesis, what is it? There is the people are exposed to the pathogen who are susceptible. Who are those susceptible people now? Smoking, COPD, and HIV patients. There is a proliferation of the microbe in the lower airways and the alveoli, because being a lower respiratory tract infection is pneumonia. Then local response and systemic response. There is two types of response. Local response, there is production of cytokines by the alveolar epithelial cells, and what these cytokines to do? They recruit neutrophils, and that will lead to productive cough, consolidation, and dyspnea. Whereas systemic response, there is again release of cytokines, and those cytokines will cause fever, chills, and rigors. Okay. Then types: lobar pneumonia, bronchopneumonia, and interstitial pneumonia. Lobar pneumonia, bronchopneumonia, interstitial pneumonia. Based on anatomical location, here entire lobe is involved, here patchy lobe is involved, here in between lobes there is a space called as interstitium that is involved. Then based on the cause, you are going to classify it as bacterial pneumonia, viral pneumonia, fungal pneumonia, and parasitic pneumonia, or it's also called as typical pneumonia and atypical pneumonia. Typical pneumonia is caused by bacteria, whereas atypical pneumonia is caused by viruses, most commonly viruses. Then the organisms causing them, it is most commonly Streptococcus pneumonia, Staph aureus, and H. influenza are the bacteria causing, whereas fungi it is Histoplasma and Blastomyces, and virus it is respiratory syncytial virus and influenza virus. So morphology: in case of lobar pneumonia, there are four stages. First stage is congestion. The lungs look heavy and boggy. That happens in first to 2 days. It looks reddish. Then stage of red hepatization. That happens 2 to 4 days. There again the gross morphology is reddish, firm, and wet. It is wet here. It is wet, and there is more of RPCs. Whereas in stage of grey hepatization, you are going to see greyish brown colored lung, which is firm, and it is dry here. It is dry. And the microscopy here, you are going to see more of neutrophils with few RPCs. you're going to draw, okay, and you're going to draw and label them. Okay, these are the red colored things, they are RBCs. The blue colored things, they are neutrophils, and they are separated by septum, and these are the alveolar spaces what I mentioned in oval. Then stage of resolution. In the stage of resolution, you're going to see liquefaction. There is liquefaction of the solid fibrinous exudates because of enzyme action. There it is becoming normal. Complications, it can organize, okay, it can become organized pneumonia, okay. Then pleural effusion can set in, abscess, empyema, and metastatic infarction. These are all the complications of pneumonia. Next, coming to the lung abscess. Lung abscess, it is a local suppurative. It is local suppurative process within the lung characterized by necrosis. You are going to see the necrosis here. You are going to see the necrosis. Cause, most common cause is aspiration. What are the organisms causing them? Streptococcus, staphylococcus, and gram-negative bacilli. What are the risk factors? Risk factors being alcoholics, anesthesia, the patients who are taking anesthesia, dental sepsis, because all these things they are going to lead to aspiration. So aspiration being the most common cause, these indirectly will lead to the lung abscess. Then preceding pneumonia, which is developing into the lung abscess. Then septic embolism and neoplasms being the obstructive causes which will lead to lung abscess. Then primary cryptogenic abscess. What is primary cryptogenic abscess? If there is any abscess formation after excluding all causes, then it is called as primary cryptogenic abscess. What are the features of lung abscess? Fever, copious, foul smelling, purulent sputum, clubbing, all these things are the features. Then complications are extension to the pleural cavity, brain abscesses, meningitis, and secondary amyloidosis are the causes. Bronchiectasis. What is bronchiectasis now? Next topic is bronchiectasis. What is bronchiectasis? It is definition: abnormal permanent dilatation of the bronchi and bronchioles with destruction of smooth muscles and elastic tissue. What are the risk factors? Risk factors are obstructive causes such as tumor, foreign body, and COPD. And next causes are diseases of mucociliary clearance such as cystic fibrosis. Then immunodeficiency conditions such as AIDS, fungal allergies such as ABPA, okay, allergic bronchopulmonary aspergilloma, ABPA. Then fibrosis and infections such as pneumonia and TB, okay, pneumonia and TB. Then coming to the types of bronchiectasis. One is cylindrical, there is full cylindrical dilatation. Varicose is, you are going to see the varicose, okay, varicose like dilatation. Last is cystic dilatation. Pathogenesis, there is some trigger, okay, there is some trigger. What that trigger will do? That will induce inflammation now, airway inflammation. Once this inflammation is set in, there is release of protease and MMPs. These are the different enzymes in the airways, and what they do, they cause permanent dilatation. Once this permanent dilatation is there, there is mucus obstruction, and there is impaired mucociliary clearance. There is excess of mucin in one place, and it is not cleared properly, and that mucin will act like a source of infection. It is infective, and again this vicious pathway will start repeating, and that infection will add on to the further inflammation. Next, coming to the morphology, in the gross you are going to see most commonly affecting the lower lobes, okay, lower lobes are affected most commonly. Microscopically you are going to see the ulceration and gross honeycomb appearance. On micro you are going to see inflammation with acute and chronic inflammatory cells are seen. What are the clinical features now? Chronic cough with foul smelling sputum and hemoptysis. Foul smelling, and hemoptysis, dyspnea, secondary bacterial infection. These are the things seen. And what are the complications which occur in case of bronchiectasis? Lung abscess, okay, abscess, fibrosis, clubbing, again brain abscess, okay, amyloidosis, lung abscess, brain abscess, and pulmonary fibrosis. Because of pulmonary fibrosis, this is clubbing, and cor pulmonale, which is a failure condition. Next, coming to the difference between the lobar pneumonia and bronchopneumonia. What is lobar pneumonia? It is affecting basically alveoli, whereas bronchopneumonia will affect the bronchi. On chest X-ray, both of them will show consolidation, but here it is dense, here it is patchy. Okay. In USG, you are going to see again consolidation, but here it is patchy. Lung involvement, it is diffuse here it is patchy. Microbiology, what is a usually organism here? It is Streptococcus pneumonia, whereas it is atypical bronchopneumonia. Mycoplasma and chlamydia are causing it. Prognosis, it is aggressive to fatal and it is less aggressive. These are the differences. So this is what about the respiratory system. Next we are going to do head and neck. In head and neck, few topics are there. We'll finish it quickly. Rhinosporidiasis. What is rhinosporidiasis? Rhinosporidiasis, it is a chronic granulomatous disease which is caused by Rhinosporidium severi. Rhinosporidium severi. It's an aquatic thing. Okay, aquatic protozoa. Then epidemiology, it is very endemic in India, Sri Lanka and Africa. Route of transmission being bathing in the stagnant ponds, auto inoculation. Okay, you are going to drink that water, that is called auto inoculation. Then hematogenous spread, if you are going to hurt it, then it will enter the body via circulation. Then clinical features, how will that look? It is reddish polyploidal bulky friable mucosa. Okay, it is reddish polyploidal bulky and friable also. In nasal cavity, it is sessile. It is sessile, gradually growing, fleshy and pedunculated. Okay. So microscope you are going to see mainly sporangia. What is sporangia? Sporangia is a group of things which is containing the sporangiospores. So this is the diagram of rhinosporidiasis, where you are going to draw the surface epithelium. Most commonly it will be respiratory epithelium, pseudostratified epithelium. Once you are drawing that epithelium, you are going to draw the sporangia. These big things are called as sporangia, which will be containing the sporangiospores. Since it's a chronic granulomatous inflammation, you are going to see what? Lymphocytes. What is the treatment of this particular rhinosporidiasis? You are going to excise the mass. Next, coming to the pleomorphic adenoma, I have not drawn the slide, so it was taking a lot of time, so I have skipped some of the histopathological diagrams. Please refer in the records. Okay, pleomorphic adenoma. What is pleomorphic adenoma? It's the most common mixed benign tumor of salivary gland, usually affecting the superficial lobe of parotid. So what are the causes? Most common it is idiopathic. It is a mixed benign. Okay, it is a mixed benign. Remember, it is a mixed benign tumor affecting the salivary gland. Okay, usually the superficial lobe of parotid. Okay, superficial lobe of parotid is most commonly affected. What is the most common cause? Idiopathic, and radiation exposure are the other causes with simian virus and SV40 viruses. What are the gross features? Gross features you are going to see single firm mobile well circumscribed encapsulated tumor. In the microscope you are going to see the pleomorphic glands. Okay, just pleomorphic glands are seen with huge glands and bigger nucleus. Those are things. Then Warthin's tumor. Warthin's tumor is also known as papillary cystadenoma. Repeat, papillary cystadenoma lymphomatosum. Papillary cystadenoma lymphomatosum. This is called as Warthin's tumor. Then definition. It's the second most common. Then benign tumor of salivary gland, most commonly affecting whom? Males. It's affecting males. 10% it's bilateral and multifocal. Rule of 10%, remember here. It is bilateral 10%. It is 10% multifocal. Means it has multiple foci. Then strongly associated with smoking. Remember, it's associated with smoking. Then gross, it is encapsulated, lobulated, multiple cysts with mucin with serous fluid. Okay, it is encapsulated, having a capsule nicely. It is lobulated, multiple cysts are seen within that capsulated thing, and that cyst will contain what? Mucin and serous fluid. It can be fixed to the skin, that is immobile in nature. Microscopy, please refer the record. Next, coming to the GIT. Okay, GIT, first it is gastric carcinoma. Definition, it's a gastric adenocarcinoma, most commonly seen of carcinoma stomach. Most commonly it is carcinoma stomach, which is a gastric adenocarcinoma. It is a gastric adenocarcinoma, most commonly affecting, most common of gastric cancer. Sorry, I'm going to repeat it properly. It's a gastric adenocarcinoma which is affecting the stomach in the 90% cases. Okay, what are the causes? H. pylori, chronic gastritis, repeated infection will lead to carcinoma. Then dysplasia, gastric adenoma, smoking, and genetic history of familial adenomatous polyposis. PJS means Peutz-Jeghers syndrome. HNPCC means hereditary non-polyposis coli. Okay, and gastric cancer itself. Types, there are many types. Classification is based on many types. One is interstitial and diffuse. Interstitial is having just interstitial variety, whereas diffuse it is called as lineatis plastica, involving the entire layer, whereas proximal and distal based on the location. Based on location it is proximal and distal. Based on depth of invasion it is early and advanced. Other four types are polyploid group. That is a polyploid outer growth, that is polyploid. Then it is ulcerative, going deep. Then being ulcerative also it is infiltrative. Here it is infiltrative. Then it is diffuse infiltrative. Pathogenesis. Basically H. pylori mechanism is very important here. So how H. pylori is important now. Normal gastric mucosa is there and the H. pylori infection will start setting in. Once the H. pylori infection will start setting in, that will lead to superficial gastritis. And superficial gastritis, after repeated exposure again, what happens? It becomes chronic inflammation. If it takes on a long variant, it is chronic inflammation. What will this chronic inflammation do? It will cause atrophy of the glands, and that's called atrophic gastritis. After this, the particular epithelium is replaced by some other epithelium, and that is called as metaplasia, and that's called as metaplasia. Once this metaplasia is set in, that is a bed for dysplasia, and dysplasia is called as carcinoma at last. So these are the things you need to concentrate. Now morphology. Most commonly where does it occur? It occurs in gastric antrum and lesser curvature are the sites of gastric carcinoma. So what are the features in the morphology? Interstitial, it is usually exophytic, whereas diffuse it is endophytic. Remember, compare them and read. It is exophytic, it is endophytic. Here you are going to see the ulceration. Here it is not, you are not going to see the ulceration, but instead you are going to see lineatis plastica, that is diffused involvement, that is gross. Whereas microscope you are going to see pleomorphic glands, okay, with mucin, that is apical mucin. Then diffuse type you are going to see discohesive signature cells, okay, signature cells. These are very hallmarking feature. Then clinical features being anemia, fatigue, weight loss, fever, anorexia. These are all the constitutional symptoms of any of the cancers. You can write for all cancers, that is anemia, fatigue, weight loss, fever, anorexia, okay. Then here particularly dysphagia versus lymphadenopathy, because the lymphatics are going to drain into the left supraclavicular node, okay, from the gastric antrum. Then hemorrhage, okay, these are the things seen. Hemorrhage usually it can be dark colored stools or that is hematemesis, that is vomiting of blood. Then treatment, you are going to do the chemotherapy. CT andre it is not CT scan, it is chemotherapy. So chemotherapy which is followed by a surgery for persons who are not having any metastasis, whereas if there is any metastasis you are going to give chemotherapy plus radiotherapy. This is the morphology. You are going to draw the glands here. In between them you are going to show the bit of inflammation, and inside you are going to show mucin, that is lumen mucin, and pleomorphic glands with big nucleus and abnormal loss of basal polarity. All those are features of neoplasm. Then at last you are going to show the apical mucin, which are marked in the center. Okay, just see above the cell you are going to see the apical mucin vacuoles. Then coming to the diffuse type, it's typically you are going to see the signature cells, which have large mucin vacuoles with abundant cytoplasm and pushing the nucleus to the periphery, that is peripheral nucleus. Next, IBD, inflammatory bowel disorders. So you know, right, what are the inflammatory bowel disorders? Basically ulcerative colitis and Crohn's are the components. Now we will see in detail what are those. Chronic inflammatory conditions of GIT resulting from inappropriate mucosal immune activation. Is seen. Components, what are the components? Basically ulcerative colitis and Crohn's. Pathogenesis, there is a bacteria because of some barrier defect it is going to enter into the cell, and once it enters into the cell it is picked by the antigen presenting cell. Which are the antigen presenting cells here? Dendritic cells. What these dendritic cells will do? They produce interleukin 23, and what they do, they present this antigen to the CD4 T cells. Once the CD4 T cells are activated, now what they do, they activate different types of T helper cells, that is Th17, Th2 and Th1. What this Th17 will do, they'll help in recruitment of neutrophils, whereas Th2 they maintain inflammation by producing interleukin 13, whereas Th1 will produce interferon gamma and tumor necrosis factor. They produce interleukin 1 and interleukin 6 and maintain inflammation. Whereas what this interferon gamma will do, it will stimulate the macrophage via classical pathway. You know, right? Classical M1 macrophage is stimulated by interferon gamma. Then what are the differences now? This is important. Distribution, most commonly ulcerative colitis. So it is just in the colon. Crohn's, it can happen any part of the GIT. Prevalence, it is more. Ulcerative colitis is more, whereas Crohn's it is less. Severity, it is opposite here. If it is more prevalent, it should be less severe, or else the patient will have so much of deaths. Then there it is more severity, Crohn's being less prevalent. Rectal involvement, here it is positive because it is occurring in colon, it is very frequently seen, whereas in Crohn's it is rarely seen or absent. Diarrhea, usually bloody diarrhea is seen in case of ulcerative colitis. Then there it is non-bleeding. Abdominal mass, it is negative in case of ulcerative colitis, whereas Crohn's, because it is involving other parts of GIT, it can cause abdominal mass. Skip lesions are seen specifically in case of Crohn's disease. Okay, this is how we are going to draw. Here fully it is affected, that is ulcerative colitis. This is skip lesions in case of Crohn's disease. Type of ulcer, the ulcer is formed in both. Here it is superficial, here it is deep. Because of the superficial ulcer there is no ability to form fistula, whereas here it is fistula forming ability. Because it is deep, it can form fistula. Then bowel wall, how will the bowel wall look? Because of ulcerative colitis repeated inflammation, it is thin, whereas Crohn's disease being transmural, it is involving all layers, it becomes thick here. And lead pipe appearance, it is seen in case of both. Okay, lead pipe appearance, it is seen in both cases if they are seen in advanced condition. Then cobblestone appearance, it is negative in case of ulcerative colitis, but it is positive in case of Crohn's disease due to deep mucosal ulceration. These are the deep mucosal ulceration in a longitudinal fashion. Whereas pseudopolyps are seen in case of ulcerative colitis. Because of superficial ulcers, the ends will lead to the formation of pseudopolyps. Here it is negative. Creeping fat, moving of fat towards the inflammation. Okay, creeping fat is negative because here peritoneal fat is outside, so this is happening inside only. It is not transmural, whereas here it is transmural infection, so the creeping pad of fat is seen. Then depth of lesion, as I told, it is only for mucosa and submucosa. Here it is transmural. Here it is transmural. Inflammatory cells, usually here it is acute plus chronic. Okay, it's an inflammation, colitis, acute inflammation which is followed by a chronic inflammation, whereas Crohn's disease, it is typically chronic inflammation only. So if acute inflammatory cells are seen, you're going to see more of neutrophils, right? So more of neutrophils are seen, and some lymphocytes are also seen. If these neutrophils, if they are clubbed together, it's called as cryptapsis, and that is present in case of ulcerative colitis, and it's absent in case of Crohn's disease. So it's being a chronic thing, what you're going to see usually granuloma, and that type of granuloma is non-caseating granuloma. Then fibrosis, acute plus chronic. So acute is predominating here more commonly, so there is no fibrosis. If there is a chronic inflammation, I told it is always accompanied by fibrosis or healing component. So this fibrosis is present, and because of this fibrosis, what you're going to see is stricture is seen. Next, serositis. What is serositis? Inflammation of the serosal layer of the GIT. So it should be transmural for serositis to happen, right? Then lymphoid response. What is lymphoid response? Lymphoid response is seen in case of Crohn's disease, because it is having more of lymphocyte aggregation, and that has led to the lymphoid response. Then strictures, because strictures I have told, stricture it is present only in case of Crohn's disease because of formation of fibrosis. Then toxic megacolon, that is acute inflammation releasing nitric oxide, and that has led to the dilatation of the things, and that is seen in case of ulcerative colitis, and it is absent in Crohn's. Obstruction, sinuses, fistula, abscesses, these are all the complications. All these complications are more common in case of Crohn's. Remember, it is more common in case of Crohn's, whether it is so. You remember that is Crohn's disease is very dangerous because of multiple complications, whereas malignancy is seen more in case of ulcerative colitis. Next, coming to the polyps of large intestine. So what are the polyps of large intestine? They are the outgrowths of the mucosa occurring most commonly in the colorectum. There are two types, non-neoplastic and neoplastic. Non-neoplastic, it is hyperplastic, inflammatory, hamartomatous. These are the three types. Whereas neoplastic, it is adenomas, FAP, that is familial adenomatous polyposis, and HNPC, that is hereditary non-polyposis coli. Then hyperplastic polyps, you are going to see decreased turnover of epithelial cells and decreased shedding, most commonly seen in left colon, and they are sessile or nodular projections which are less than 5 mm, single or multiple, and they have serrations. These are the things which are difficult to memorize, but still it happens. Next, coming to the inflammatory polyps, they are solitary. Remember, these are solitary. Since they are inflammatory, they will be ulcerated or polyploidal due to delayed relaxation of the anorectal sphincter. You are going to see these things, and they are very far, that is 4 to 18 centimeters from the rectal opening. What are hamartomatous polyps? Hamartomatous polyps, they are sporadic, means they can happen anywhere. They are associated usually with syndromes. They have high risk of malignancy. There are two types you are going to remember. One is juvenile and one more is Peutz-Jeghers syndrome, PJS. Juveniles, they are solitary, but they are decreased risk of malignancy, whereas Peutz-Jeghers, it is very high risk. What does it have? It has hamartomatous polyps in the GIT and with cutaneous hyperpigmentation. Remember, juvenile polyps because of SMAD mutation, whereas Peutz-Jeghers syndrome, PJS, is because of STK11 mutation. Coming to the neoplastic polyps, you have only adenomas to cover here. In the adenoma, they are neoplastic, again I have mentioned, and they are the most common precursor of adenocarcinoma colon. They are again solitary. They are sessile or pedunculated. Size, if they are less than 1 centimeter, it is having low risk of malignancy. They are more than 4 centimeters, then they have high risk of malignancy. What are the types? Tubular, tubulovillous, and villous. These are the three varieties of polyps. So this is how we are going to draw tubules, like, then tubulo with villous inside, then villous branching pattern. So how will this adenoma will lead to carcinoma? If they are going to ask, you are going to draw this flow chart. So loss of APC, okay, there is a gene called APC, that gene is lost, and there is a mutated beta catenin. So once this all happens, what happens? There is a failure of degradation of beta catenin by APC. So APC and beta catenin, they are not occurring together, and there is a degradation of beta catenin now. So this beta catenin is not degraded, and they accumulate, and once it is accumulated, what it do? It will not sit simply, it will translocate home, MYC and cyclin D. Remember them, right? In the cell growth factors, they promote the cell proliferation. This MYC pathway and cyclin D, they are good, and they promote the cell proliferation, and that will lead to adenocarcinoma colon. Coming to the Barrett's esophagus. What is Barrett's esophagus? It is a intestinal metaplasia of distal esophagus. It is intestinal metaplasia of distal esophagus, It is an example for what? It is an example for columnar metaplasia. Okay, columnar metaplasia. Pathogenesis: repeated acid reflux such as GERD will damage the stratified squamous epithelium, which is commonly present in the esophagus, and on the repeated exposure of GERD, that is replaced, there is a stem cell reprogrammation. Stem cells get reprogrammed. After the stem cells are reprogrammed, that will lead to the formation of columnar epithelium. So on the microscope you are going to see mainly goblet cells and dysplastic pleomorphic cells. These are the cells seen on Bayard's esophagus microscopy. Then endoscopy. What are the endoscopic features here? Tongue-like areas. Okay, tongue-like areas with red velvety mucosa. It looks very reddish velvety mucosa like a tongue. Then on the treatment, if it is low grade, you are going to just follow up with endoscopy and biopsy, whereas if it is high grade, you are going to do the surgical resection. You will not take the risk, you are going to excise the tumor there. Then linitis plastica. What is linitis plastica? It's a diffuse type of gastric carcinoma. It occurs where it occurs when there is extensive involvement of stomach. If most of the layers of the stomach is involved, then it causes this particular appearance, and what that particular appearance will lead to leather bottle appearance. And leather bottle appearance is because of what? The ability of the stomach to lose its ability of forming rugae or foldings. Usually rugae or foldings will be present in the stomach, but because of this diffuse involvement of the gastric carcinoma, then that will lead to the loss of rugae or foldings, and that will lead to a leather bottle like appearance. In the old eras, they used to drink with that leather bottle. Remember Pirates of Caribbean, all those things. Then mutation, what you are going to see? E-cadherin loss. The cells can't hold each other. Cadherin is the one which will help the cells to hold together. So here there is E-cadherin loss, and because of that, linitis plastica can occur more. And the microscopy, since it is a diffuse type, what you are going to see? Discohesive signet ring cells. I have told, right? In the diffuse pattern, you are going to see very specific cells with peripheral nucleus and abundant cytoplasm with huge and containing maximum mucin. Okay, we are done with the GIT. Now we will move to liver. We are going to move to liver. In the liver, what is the definition of alcoholic liver disease? The harmful effects of the excess alcohol which cause to liver, that is called as alcoholic liver disease. What are the forms? First is steatosis, fatty change. Next is alcoholic hepatitis and cirrhosis. These are the three forms. First, fatty change will occur, then alcoholic hepatitis, lastly it is cirrhosis. Remember, these are the things: fatty change, alcoholic hepatitis and cirrhosis. Risk factors: women's. Okay, usually women's, because of increased estrogen, they have risk factor. Then whites, then comorbid conditions such as diabetes, malnutrition, hepatitis B infection, hepatitis C infection, all will this contribute to non-alcoholic fatty liver disease. Pathogenesis: what happens if you are going to take alcohol repeatedly? It is forming increased acetaldehyde. Once this increased acetaldehyde is formed, what happens? There is a formation of endotoxin, and this endotoxin will act on Kupffer cells, and these Kupffer cells, what they do? They release TNF alpha. What this TNF alpha will do? It will act on the hepatocyte and will start inflaming it. Okay, it will act on hepatocyte and start inflammation, and once the inflammation will occur, first it will be acute, then later it will become chronic with collagen synthesis and liver fibrosis. This is one, because of endotoxin activation of acetaldehyde. Then cytochrome P50 enzyme is activated. Because of this, there is oxidative stress and lipid peroxidation that lead to hepatocyte cell injury, that lead to ALD. Next, because of this acetaldehyde, there is increased NADH production. Because of NADH production, there is again increased lipogenesis and decreased fatty acid oxidation. In the biochemistry, what you have learned, right? NADH, it will cause, what is the fate of NADPH or NADH? It is increased lipogenesis and decreased fatty acid oxidation that will lead to fatty liver. Again, this fatty liver is a cause for alcoholic liver disease. Morphology: what is morphology? Gross. The liver is looking enlarged, soft, greasy and yellowish. in case of steatosis. Microscopically you are going to see microvesicular steatosis and macrovesicular steatosis, that is fatty change. Next, coming to the alcoholic hepatitis. In the alcoholic hepatitis, it is microscopy. What you are going to see is ballooned hepatocytes, huge. They have become big. See here, the normal hepatocyte is this, but here it has become big. That is ballooned hepatocytes. Then it is Mallory-Denk bodies. What are these Mallory-Denk bodies? These are the Mallory-Denk bodies. What are these? They are degenerated hepatocytes with eosinophilic cytoplasmic inclusions. Okay, they are degenerated hepatocytes with eosinophilic cytoplasm inclusions. Mallory-Denk bodies seen in case of alcoholic hepatitis. Then you're going to see the inflammation with neutrophils and lymphocytes. Okay, neutrophils and lymphocytes. And lastly, since lymphocytes are there is chronic inflammation which is always associated with fibrosis. That is called as Spice-Mill fibrosis. Next, coming to the clinical features, weight loss, anorexia, abdominal discomfort, tender hepatomegaly are the clinical features. Lab diagnosis, you are going to see in the steatosis, you are going to see just mild. It is mild. Okay, here it is mild, here it is more. All the things it is more here. In steatosis, what is the things you are going to see? It is mild increase in the bilirubin and alkaline phosphatase. Whereas in hepatitis, what you are going to see is massive increase in SGPT, SGOT, serum bilirubin and serum alkaline transaminase. Okay, ALT is increased. Next is alcoholic cirrhosis. Mainly what you are going to see, neutrophilic lymphocytosis, maximum neutrophil is formed. Then hypoproteinemia, because the cirrhosis is there and the liver is not producing the proteins, and hypoproteinemia has occurred. And reversed albumin globulin ratio, there is no formation of albumin now, so albumin will start decreasing and globulin will start increasing, and that will lead to reverse in the AG ratio. Lastly, anemia is also there because so many factors which are required for synthesis of RBCs are produced from liver, so anemia is there. So this is the flow chart. Basically, first this is healthy liver. If you are going to abuse with alcohol, it will become hepatic steatosis or it will become alcoholic hepatitis. Okay, again, if hepatic steatosis and alcoholic hepatitis, if you are going to abuse with alcohol, it will become hepatic cirrhosis. But hepatic steatosis and alcoholic hepatitis, they are reversible. If you are going to abstain from alcohol, it will become back to healthy liver. Next, chronic hepatitis. What is chronic hepatitis? It is a liver inflammation that lasts at least 6 months. Ranging from mild, and non-progressive to severe, leading to cirrhosis. What are the causes? Hepatitis B virus, hepatitis C virus, non-alcoholic fatty liver disease, alcoholic hepatitis, autoimmune hepatitis, genetic and drug causes. Hepatitis B infection, what does it do? First, it is acute hepatitis B infection. Then it will become chronic. It will last for 6 months. It will become chronic and it will cause chronic hepatitis. Once chronic hepatitis is formed, it will cause cirrhosis, and cirrhosis will lead to hepatocellular carcinoma and liver failure. Simple. Next, what are the lab diagnosis? HbSg positive, then HBV DNA more than 10 to the power 5, then persistent increase in the ALT and AST. What is the treatment there? Tenofovir and lamivudine and interferon alpha. Next, HCV infection. How are we going to deal again? Same way, 15% the people will undergo recovery, whereas 85% will go for chronic. It is very severe. Remember, 85% people will go for chronic directly, and that will lead to cirrhosis and hepatocellular carcinoma. Diagnosis again, HCV RNA is positive. HCV being an RNA virus, HCV RNA being positive. Then increased anti-HCV antibodies in the body. Okay, anti-HCV things. Then increased ALT. What is the treatment? Velpatasvir and ledipavir. Okay, these are the things, with or without ribavirin. Non-alcoholic fatty liver disease. It is having so much of spectrum. One is fatty liver, then it is non-alcoholic steatohepatitis, last is cirrhosis. It is a diagnosis of exclusion. Okay, you are going to diagnose all other conditions. If they are all negative, then it is called as non-alcoholic fatty liver disease. Clinical features are fatigue, tender hepatomegaly, that is right upper quadrant pain, then hepatomegaly, obesity, hypertension, all these are the things. Next, autoimmune hepatitis. Autoimmune hepatitis is particularly periportal, just around the portal vein. It is causing inflammation and it is very specific and it is chronic also. Since it's a chronic, it is associated with lymphocytic infiltration. Basically, what is most common or most hallmark feature here is plasma cells. Plasma cells are hallmark with piecemeal necrosis. What are the types of autoimmunes? 1, 2 and 3. So basically autoimmune type 1, it is associated with ANA positive. This particular antibody, that is ANA antibody, is positive in case of type 1. In case of type 2, it is anti-LKM positive. Anti-LKM positive. In case of type 3, it is SLP positive. SLP positive. And you're going to see increased IgG titers. You're going to see increased IgG titers. How are you going to treat the condition? Because of so much of inflammation being an autoimmune condition, you're going to halt the inflammation. How are you going to halt the inflammation? You're going to give the glucosteroids, which is the fast acting glucosteroids. Short acting glucosteroids are very quickly acting, that is prednisolone. How much you're going to give? 30 mg per day. Okay, that is 10 mg TID. That is a loading dose. Later it is converted to 15 mg per day. First it is 30 mg, then it is 15 mg, remember. So we are done with liver. Moving to, so one more topic is there in liver, that is a classification of cirrhosis. Based on etiology, it is mnemonic is camp B. C for cardiac cirrhosis, A for alcoholic cirrhosis, M for metabolic cirrhosis, P for post-necrotic cirrhosis or post-viral cirrhosis, B for biliary cirrhosis. Based on gross, it is micronodular, macronodular and mixed. If it is micronodular, how much it should be? It should be less than 3 mm, whereas macronodular should be more than 3 mm. Okay. This is what about the liver. Next, moving on to the pancreatitis. What is pancreatitis? It is a reversible parenchymal injury to pancreas due to inflammation. It is reversible parenchymal injury to pancreas due to inflammation. Parenchymal injury to pancreas, which is reversible due to inflammation. Causes. What are the causes? Alcohol, gallstones, genetic mutations such as trypsin and mumps infection, shock, thromboembolism, drugs. These are the things. Shock, thromboembolism, drugs. Pathogenesis. What is the pathogenesis? Duct obstruction and alcohol and drugs other cause. What they do, duct is getting obstructed, because of that it lead to ischemia. Alcohol and drugs, what they do, they activate unwanted enzymes and that lead to enzyme activation. Both of these what they do, ultimately they are going to cause acinar cell injury. Once this acinar cell injury is there, what it does, it activates enzymes. So if these activated enzymes are seen, what are the things you're going to see here? These are the key things you must remember. One is interstitial inflammation and edema. Next is proteolysis leading to parenchymal destruction. Then fat necrosis. Next is vasculitis with hemorrhage. All these ultimately will lead to acute pancreatitis. Hereditary pancreatitis, what is it? Repeated attacks of severe pancreatitis. Is hereditary. Because of what mutations? You're going to remember CFTR mutation and PRS mutation. PR and SPINK mutation. Whichever is easy, you can remember. SPINK mutation, CFTR mutation. CFTR mutation, you remember, right? It happens in cystic fibrosis transmembrane regulator. That is what? The CFTR. So it is easy to remember. SPINK mutation, CFTR mutation in case of hereditary pancreatitis. Next, morphology. We are going to see swollen indurated edematous pancreas. Microscopic, what you are going to see, since pancreas is rich in fat and having lipase, it is going to cause the enzymes are activated and that will lead to fatty necrosis. Then fibrosis. Forms of acute pancreatitis. It is interstitial type, necrotizing type, hemorrhagic, biliary. Okay, infected, okay, and post operative. These are the types, other forms, okay, you can just remember them. Clinical features are severe epigastric pain. It will be such severe that the patient can't even bear, okay. Severe epigastric pain and radiates to upper back and shoulder because of diaphragm irritation. And nausea, okay, nausea and vomiting and loss of appetite. Severe epigastric pain radiating to upper back and shoulder and loss of appetite. Lab diagnosis: increased serum lipase, increased serum amylase with hypocalcemia. Why this hypocalcemia is occurring? Because of fatty necrosis. Those all calcium soaps are formed which in the fatty necrosis come out, and that will lead to hypocalcemia in the blood. Complications are disseminated intravascular coagulation, acute respiratory distress syndrome, sepsis, acute tubular necrosis, and chronic pancreatitis are the complications. How are you going to treat? You are going to keep the patient nil per oral. You are not going to give anything from the mouth. Then IV fluids, aggressive IV fluids. Which are the IV fluids of choice? One is RL or 5% DNS. 5% DNS, that is dextrose normal saline. Then analgesics, IV analgesics to keep the pain low. Then IV octreotide if he is alcoholic, and IV thiamine if he is alcoholic. These are the things you are going to do for acute pancreatitis. Then cholelithiasis. What is cholelithiasis? Gallbladder. Cholelithiasis is presence of gallstones within the gallbladder or extrahepatic biliary system. Within gallbladder, it should be within gallbladder or extrahepatic biliary system. What is the cause? It should be middle-aged individual, perimenopausal lady, obesity and diabetes person, rapid weight loss. Remember, rapid weight loss is also cause for cholelithiasis. Then OCP taking females or women's. Okay, these are the risk factors or causes. Types. What are the types there? Cholesterol stones, pigment stones, and mixed stones. These are the types. Then pathogenesis. How are these formed? Because of increased activation of HMG-CoA reductase and one more enzyme, that is 1-alpha hydroxylase. I don't remember, in the biochemistry we have been taught. Because of that, what happens? There is increased cholesterol and decreased bile salts, okay. Because of this, what happens? There is saturation of these things. What things are formed? These stones, they are getting saturated. Because once they are getting saturated, they become nucleation process. Nucleation promoters are seen, and these nucleation promoters, what they do? They create nucleation. So the formatted stones, they are having some nucleus. Then there is formation of microstones, okay. Small stones are formed. Later these small stones, they fuse together to become a big growth, and that is called as gallstone. What is a feature there? Typically colicky pain. Remember, right? Colicky pain in the right upper quadrant, or in the epigastrium. This is what is seen. Then what are the complications basically? So basically when it comes to cholelithiasis, that is stone. Because of stone, there is obstruction, okay, obstruction, and that particular obstruction can lead to inflammation, and the infection of that particular gallbladder is called as acute cholecystitis. Then it is gallstone pancreatitis. Because of this gallstone in the pancreatitis, I have mentioned causes as gallstone, and gallstone will lead to pancreatitis, that is acute pancreatitis. And if the gallstone is present in the ileum, that is called as gallstone ileus. These are the things you must concentrate. So in this aspect I have covered blood, cardiovascular system, respiratory system, head and neck, GIT, liver, and pancreas. Being the first part of the general path video, the other half of the general path video will be uploaded a bit later. So stay tuned for uploading of rest all things such as CNS, soft tissue, endocrine, male and female genital organs, kidney, okay. All these things will be uploaded late. Breast, okay. Thank you. If you like the session, please subscribe and promote my video. Thank you. See you in the next video.